Good morning. I'm Dr. Manisha Gupta, Professor and Head Department of Obs and Gynae. I will be taking a lecture on preterm labor, premature rupture of membranes. So, how do we define preterm labor? It is defined as where the labor starts before the 37th completed week. The lower gestation is not uniformly defined, whereas in developed countries it has been brought down to 20 weeks, and in developing countries it is 28 weeks. Preterm birth is a significant cause of perinatal morbidity and mortality. The prevalence widely varies and is around 5 to 10%. Preterm birth occurs in 5 to 12% of all pregnancies and accounts for majority of neonatal deaths and morbidity. A neonate weighing 1 kg to 1.5 kg today has 10 times greater survival chances of survival. So the rate of spontaneous preterm births is decreasing while induced preterm births are increasing. Neonatal morbidities are mainly due to organ maturity. Coming to the etiology, in about 50% idiopathic and multifactorial are the causes. High risk factors, history, there is an increased incidence of preterm labor in cases such as previous history of induced or spontaneous abortion or preterm delivery, pregnancy following assisted reproductive techniques, asymptomatic bacteriuria or recurrent UTIs, smoking, low socioeconomic strata, and poor nutritional status and maternal stress. Complications in present pregnancy, their pregnancy complications such as preeclampsia, antepartum hemorrhage, premature rupture of membranes, polyhydramnios, uterine anomalies like the subseptate uterus or unicornuate uterus, also cervical incompetence, medical and surgical illness like acute fever, acute pyelonephritis, diarrhea, acute appendicitis, toxoplasmosis, and any abdominal operation, chronic diseases like hypertension, nephritis, then diabetes, decompensated heart lesion, or severe anemia. Genital tract infection like bacterial vaginosis, beta hemolytic streptococcus, etc. Iatrogenic, like indicated preterm delivery due to medical or obstetric complications. Idiopathic are the majority, where premature effacement of the cervix with irritable uterus and early engagement of the head are often associated in the absence of any complicating factor. The fetal causes could be multiple pregnancy, congenital malformations, and intrauterine death, placental infarction, thrombosis, placenta previa, or abruption. So, pathophysiology mechanisms that lead to onset of premature labor are complex and multifactorial, but it is likely to occur as a result of concomitant activation or a cascade of the following events like functional progesterone withdrawal, which leads to increase in the corticotrophin releasing hormone, premature decidual activation, increased prostaglandin production, oxytocin initiation, and increased cytokine production. So, how will we diagnose preterm labor? By clinically examining the patient and finding out that there are regular uterine contractions with or without pain at least one in every 10 minutes, dilatation more than 2 centimeters and effacement more than 80% of the cervix, length of the cervix as measured by transvaginal ultrasound is less than 2.5 centimeters and we find there is funneling of the internal os, pelvic pressure, backache, and any discharge or bleeding as complained by the patient. Full blood count, urine for routine analysis, culture and sensitivity, cervicovaginal swab for culture, and fibronectin ultrasound for fetal well-being, cervical length and placental localization, serum electrolytes and glucose levels for tocolytic agents. Management. Principles of management are glucocorticoids to the mother are given to prevent neonatal RDS, intraventricular hemorrhage, and NEC. Antenatal transfer of the mother with the fetus in utero to a tertiary care equipped with NICU. Tocolytic drugs are in the meantime given to the mother to buy time for the transfer or for the glucocorticoids to be active. To Antibiotics are given to prevent neonatal infection. Magself is given as a neuroprotector to the mother for the baby to prevent neonatal cerebral palsy when pregnancy is less than 34 weeks. Careful intrapartum monitoring, minimal trauma, and presence of a neonatologist during delivery is mandatory. Vaginal delivery is preferred unless there are other obstetric indications. Now, management during labor is our aim is to prevent birth asphyxia and development of RDS and to prevent birth trauma. So first stage, the patient is put to bed to prevent early rupture of the membranes and she's to ensure adequate fetal oxygenation. Epidural analgesia is given or sedation is given to allay anxiety. Labor should be carefully monitored. Cesarean delivery, obstetric indications, and second stage, the birth should be gentle and slow to avoid rapid compression and decompression of the head. Episiotomy should be given. Tendency to delay is curtailed by low forceps. The cord is to be clamped immediately at birth to prevent hypovolemia and hyperbilirubinemia, and neonatologist should be present. So thank you. How do we define premature rupture of membranes? It is spontaneous rupture of membranes at any time beyond 28th week of pregnancy but before the onset of labor, or when the rupture of membranes occurs before 37 weeks, it is called preterm premature rupture of membranes. If it occurs more than beyond 37th week, it is term PROM. Rupture of membranes more than or 24 hours are called as prolonged rupture of membranes. Incidence is around 10%. What are the causes? Idiopathic, increased friability of the membranes, decreased tensile strength of the membranes, polyhydramnios, cervical incompetence, multiple pregnancy, infection of any kind like chorioamnionitis, UTI, and lower genital tract infection, cervical length less than 2.5 centimeters prior preterm labor, or low BMI less than 19 kg per meter square. Now, how do we diagnose? To look for vaginal discharge and to examine the collected, sorry,